So a very good afternoon, morning and evening to all. I'm Priya Balasubramaniam, a public health and health systems scientist affiliated with the Public Health Foundation of India and the Center for Sustainable Health Innovations here in Singapore. On behalf of our partners, the Institute of Development Studies Sussex, Ikigai Law New Delhi, and Transform Health, it's my pleasure to welcome you to the Mutual Learning series on digital health ecosystems. The objective of this digital dialogue series is to examine evolving digital health interventions through a health systems lens to better understand and prepare for more inclusive, integrated, and accountable digital health models during and beyond the pandemic. Today's digital dialogue will focus on matters of accountability, regulatory frameworks for driving safe digital healthcare adoption in India. Our panelists will discuss how an ideal legal and regulatory framework would look like that brings out the rights and liabilities of all stakeholders concerned, and also how sound regulatory architecture has the potential to influence and impact health outcomes in a positive way. The format of today's roughly 85-minute session will involve a 5 to 6 minute presentation by Ikigai that touches on three key issues under various laws: telemedicine practice guidelines of 2020, the medical devices regulation, and health data, followed by opening remarks from each panelist that will segue onto a broader discussion on what they see as key issues that need to be resolved to safely integrate digital health tools in healthcare delivery and access. We do encourage audience interaction, so please feel free to ask questions during the session via the Q&A option on your screen, as well as the chat option. It is now my pleasure to introduce our speakers of the session and the moderator for today's session. We have Dr. K. Madan Gopal. Dr. Gopal is a public health professional working on issues related to health systems reform and strengthening in India for over 3 decades. He's currently a senior consultant health at the Niti Aayog, the National Institution for Transforming India, the Apex Policy think tank for the Government of India, and contributes to various transformative health sector programs, including the National Digital Health Mission and the COVID pandemic response. We next have Dr. Uma Nambiar. Dr. Nambiar is the CEO of Dalmia Healthcare and the Managing Director of Zeden Life Sciences. She's also chairperson of the Digital Health India Association. She's a trained neurosurgeon and health system specialist with expertise in strategic planning, healthcare policy design, healthcare quality monitoring, and the use of information technology in healthcare. A passionate believer in digital health systems being an enabler for accessible, ethical, and affordable healthcare, she devotes considerable amount of time and energy to promote its implementation at all levels in the health ecosystem. And finally, we have UBCare Health, represented by Mr. Sridhar Pillalamari. Mr. Pillalamari is the CEO and co-founder of UBCare Health Private Limited. He has held global leadership positions in various organizations over the last 33 years. UBCare Health is a startup that has been recognized in enabling specialized medical care to patients at home. UBCare uses digital health, telemedicine, and collaborative workflows to build hybrid healthcare pathways that extend secondary and tertiary care away from hospitals. Prior to founding UBCare, he was managing director of Max Linear India. And finally, I would like to hand over the session to our moderator for the day, Ms. Srinidhi Srinivasan. Ms. Srinivasan is the principal associate at Ikigai Law. She comes with a deep focus on technology law and strong policy advisory backgrounds. She is engaged with a diverse set of stakeholders in the technology and policy ecosystem, including governments, ministries, as well as companies. At Ikigai, she focuses on data governance, health technology, and e-commerce. And finally, my co-facilitator for this series, Professor Jerry Bloom, who's a fellow at the Institute of Development Studies, University of Sussex, and he will wrap up with closing remarks at the end of the session. Over to you, Srinidhi.
Thank you so much, Dr. Priya. Very good afternoon to everyone who's tuned in. It's great to be here with this wonderful panel of speakers today Dr. Gopal, Dr. Nambiar, Mr. Sridhar, thank you so much for joining us, and I'm really looking forward to this conversation. Thanks also for that introduction, Dr. Priya. I think at Ikigai Law, we have a sharp focus on law, technology, and innovation, and health has been a key area of focus for us, and we've been following this space closely for the past couple of years. And our goal today is to really dig into the legal landscape for digital health across a couple of themes and get our panelists' thoughts on it. We've seen an explosion of digital tools and platforms in the healthcare delivery space, and we expect more and more of that in the coming years, especially with the government's policy initiatives around digital health, like the Ayushman Bharat Digital Health Mission and several other initiatives. And at this stage where we're anticipating a massive rise in scale, we really hope to understand the successes of our current regulatory system and pitfalls and potential challenges. There's a really wide range of laws that addresses different aspects of health, and we'd love to hear from our panel today and on how these laws can best serve patient outcomes while also ensuring accountability and also enabling innovation. And we hope that the takeaways from this session can lead into further discourse on what the law and policy framework should look like. I'll just do a very quick overview of the laws that we hope to dig into across three big themes. And after that overview, I'll invite our speakers for their opening remarks. So digging right in, there is of course a varied set of stakeholders and a range of tech tools and platforms that have emerged in this space. We see specialized platforms for telemedicine and for healthcare delivery, as also general communication tools that are used or adopted by doctors and patients to interact. We see specialized healthcare products that support physicians in diagnostics and post-op care or for monitoring patients. We see direct to sort of consumer products, a plethora of apps and wearables that track calories you consume, track your heartbeat, menstrual cycles, or allow you to journal your mental health. And there are multiple stakeholders involved. There are platform developers, those involved, service providers in the chain that focus on, say, AI, ML solutions, physicians, practitioners, and allied healthcare professionals. And there are laws governing each of those segments. And we'll just show a brief sort of snapshot across the spectrum of these laws for telecom, for telemedicine, for healthcare products, for health data, and for professionals. And we hope to really dig into three big themes for today. First is telemedicine. I think in March of 2020, close to around 2 years back, when the pandemic had just begun, the government had notified the telemedicine practice guidelines. This was a much needed sort of formal recognition of the practice of telemedicine. But the guidelines were more of a starting point. They left a lot of the details up to the doctors who were to decide the choice of platform, which platform would be most ideal for using or for interacting with a patient, whether a specialized tool or a general chat over phone or WhatsApp. It left it up to the doctors to sort of also decide whether a teleconsult will be the right way forward. It prescribed a set of medicines that doctors could prescribe, depending on whether it's the first consult or if it's a follow-up consult, and a set of medicines that you simply cannot prescribe through a telemedicine mechanism. And importantly, for tech platforms, it set out a list of do's and don'ts, which are also fairly bare bones. I understand the most important of these could be that AI platforms and AI cannot directly counsel patients or cannot directly prescribe medicines. It can definitely, an AI tool can definitely supplement or support a doctor in diagnosis or in post-op care. And there again, this theme of kind of shifting the onus onto the physicians and the doctors. Now that we're at this 2 year mark, we're close to it being sort of 2 years of the guidelines. And perhaps there's a need to kind of examine what more can be done in this space. How have the guidelines enabled and what are the sort of restrictions and challenges that have sprung up along the way. The second big theme that we hope to discuss is just on healthcare products. Beyond telemedicine and telecommunication, there are several other products, specialized health products that have emerged in the market. And central to all of these perhaps has been the idea of building trust to ensure that these are safe for use by doctors and patients, that these enhance patient outcomes, that these are evaluated and serve the cause for which they were developed. And a couple of years back, within the regime of the Drugs and Cosmetics Act, and the medical devices framework, the government also notified that standalone softwares and accessories that aid diagnostics or treatment or cure of a disease could also be classified as medical devices. And based on the level of risk associated with a tech platform or a software function, like with any other medical device, they may also undergo a registration or a vetting process, going forward an approval process as well, which would involve reaching out to the CDSCO at the central level or the state drug controller authorities. And a couple of questions that come up here are, what could be the evaluation process that we follow for an AI ML tool that is used in a clinical setting? What do we need to calibrate that for a clinical sort of framing? And the idea that medical devices and in particular software functions, whether they should continue to be regulated under the aegis or the umbrella framework of the Drugs and Cosmetics Act. And the third big theme that we hope to discuss today is that of health data and health data management. As we move to digital tools, increasing adoption by doctors as well as consumers and patients, there is a vast amount of sensitive health data which is now online, which is shared, processed, collected, and generated online, leaving behind a digital footprint as well. And how that data is managed does play a key role in enhancing patient rights, privacy being one among them, privacy and confidentiality. India is close to finalizing its comprehensive standalone data protection law, under which health data is recognized as sensitive data. What that means is it comes with certain heightened obligations when it comes to how you take consent from users, when it comes to health data, where that data can be stored, what are the kinds of other sort of requirements around how do you design a product in a way that it's privacy protective and so on. In parallel, under the digital health mission, under the government's Ayushman Bharat Digital Health Mission and the National Health Authority, there is a health data management program, which also there is a push to develop some kind of standards for health data in particular. So here also would love to understand and get our panelists' thoughts on how do we leverage existing laws and standards? What are our hopes when it comes to the data protection law and these different regulators also that will be set up or that are currently existing in the framework? I think with that, I'll pause and I'll invite our speakers to come in with their opening remarks. Perhaps if I could come first to Dr. Gopal. Dr. Gopal, the government has made a big push towards digital health. It's been a key area of focus in the past couple of years, and several of these initiatives have been conceptualized and led by Niti Aayog's vision. And I'd invite you to share your thoughts on the government's vision, the current sort of set of challenges and upcoming priorities when it comes to ensuring safe digital healthcare delivery.
First of all, I accept my thanks for giving this opportunity to share my thoughts and views regarding the digital mission. You have rightly mentioned that the telemedicine practice guidelines, which were released in 2020, has been a game changer for the digital health. But nevertheless, we should understand that how this telemedicine practice guidelines came into existence. When the country went into lockdown during the month of March, there were a lot of people who were comorbid and they required follow-up care. And the honorable courts have taken cognizance of whatever teleconsults, whatever WhatsApp chat and other modes of electronic communication. They have taken a cognizance of that, and many of the people were paralyzed based on that. To enable that thing, we thought that we should push for these guidelines. And fortunately, at that time, Niti Aayog was having an advantageous position with our member being the chair of the Board of Governors of erstwhile MCI. We we both push for the this telemedicine guidelines so that it can enable the people and can result in continuum of care of these people, comorbid people. To see that, having said this, we have opened the door for innovations. Challenges usually results in innovation, and it has proven that. You have seen that it was only meant for catering the follow-up patients for whom the hospitals were closed. So all the hospitals were dedicated towards COVID management. To cater to that, now you see that how this this innovation, this practice guidelines have resulted in a home-based care management. It has given confidence because if I were supposed to do a teleconsult, I don't know whether the court will allow it or not. But this telemedicine guideline they have facilitated, it has been a game changer, and it is going to be a game changer in the coming days also. So one thing, it is evolving. We have to see that how we standardize it, how we make see the quality of the teleconsults which is happening. It's an evolving thing. That's why the good perfect should not be the enemy of good. We worked on that high level principle. So we started it, so we opened it. And you have seen that the confidence is there, home-based management of the care has happened. Apart from that, the digital devices were there, which have aided in the home care management. And that's why with a limited health infrastructure, we could manage this pandemic till now. And in the current wave also, with the majority of the people, they are getting treatment at homes. This telemedicine practice guideline as well as the digital aid in the form of digital thermometer. Every household now would be having a digital thermometer. Then you are having a pulse oximeter. Otherwise, it was very difficult to monitor the oxygen saturation in a patient. This compounded with teleconsultation, the setting up the command centers. In that way, it has revolutionized the management of the COVID care as. But this journey has not been from now only. The efforts started right from the 2011 when the Clinical Establishment Act was enacted, in which electronic health records were mandated. And some efforts have also started from that. If you look at the landscape of the ministry's program, we are providing healthcare services to each and every individual who are hooked to the system, to the private sector, to the public sector. In the public sector, you are having many programs to cater to the different needs. If somebody is getting services under malaria program, the malaria program would be having that information. Somebody from the disease surveillance program, the IDSP program would be having that. So we thought that if a similar data is collected for a single person, why can't we have an integrated? So integration steps towards integration started during the early quarters of this around 2010-11. Then we have found that the integrated health information platform rolled out, in which all the modules can write, and with a common identifier, these programs can talk to each other, so that you can have an individual level data from the different programs, and you can analyze and see what kind of data is available for that particular thing. When the when the Ayushman Bharat, because after when the one more impetus was given when during the RSBY days, when we have used the smart card for doing the transaction, that has also given confidence that we can further leapfrog and use a different kind of technology for using this kind of models. When Ayushman Bharat PMJ program was launched, we thought that let us adopt the systems which are available, then we can have a PMJ 2.0 version, and simultaneously we can make a health stack. The whole of the journey of the digital nation with having a health stack. We thought that we should be having a health stack, and in this health stack with a common identifier, all the programs, all the data can be talking to each other. With that vision, the National Digital Blueprint was made, which forms an architecture for the health mission in the country. And through that, you might have seen that how the things are moving. Last year, the National Digital Health Mission was rolled out, and the first objective is to see that how we have the digital ID for the doctor, digital ID for the institution, and digital ID for the patient. That is electronic health record for the patient. And as the scheme evolved, as the things are evolving, you don't know, you can't be having a perfect solution for everything. We started with 6 things. Now the COVID has been also adopted by this thing. With the COVID coming in a big way for management of the vaccination program in this, anybody using a Aadhaar based identification in COVID, automatically electronic health record has been created for that person. So that kind of facility is there. So that means if somebody has used it, so many electronic health records are being created. Now the challenge is that how to use these electronic health records. Of late, I just cite an example that regarding the data privacy and other things in India, who is bothered about the data privacy? I don't know. Yesterday, I brought something. I have to provide all my Aadhaar, PAN number, everything. They have taken it. There was no question. If I don't provide it, I will not get the stuff which I wanted. It was a big purchase. I have to provide everything. There's nothing like that. But once it comes to the health, electronic health records and the electronic medical records, these are 2 segments which the digital mission is working. As things will evolve in the coming days, you will find a lot of integration between all the aspects, because one way you are digitalizing the IDs of the doctors, the other is digitalizing the institution, then you are digitalizing the patient records. The other program, the Integrated Health Information Platform, that is also collecting information from the rural areas and the other programs. Now, when the Ayushman Bharat PMJ was conceptualized, it was having 2 arms. One was the health and wellness centers, the other was the PMJ, which looks after the secondary and the tertiary. The primary care element, that's the gatekeepers, which they call in the Western parley. That information is coming from health and wellness center, and in the coming days, you will be seeing that both these programs will talk to each other, and the individual records will be used. In NITI's 2035 documents for health surveillance, also we have advocated the use of the electronic health records for monitoring the individual health events. So in the coming days, you will be listening a lot about this thing. The medical device bill and other things, as the questions will come, I will be answering to that. But I will stop here. So over to you, please.
Thank you. Thank you so much, Dr. Gopal, for that. I think several themes to pick on there, from privacy to access across the rural-urban divide as well. And I'll come back to you with a follow-up set of questions. But I'd like to invite next perhaps Dr. Nambiar to make her opening remarks with your experience in digital health over the past several years. Any sort of big successes that you'd want to highlight, challenges, pitfalls with the regulatory system and yeah, with the policies. Dr. Nambiar.
Yeah, thank you so much, Srinidhi. So let me pick up from Dr. A little bit from where Dr. Gopal has left, and mainly I would like to speak on the TPG guidelines. Whereas telemedicine has been in India over the last 17 or nearly 20 years, but it never really became popular, and it was never legal to really practice telemedicine. And there was no way that you could actually charge fee for it. And because you could not monetize it, it never became popular. So TPG guidelines made one thing possible, which fearlessly allowed doctors to consult through a telecommunication medium. So yes, as a crisis management tool, when the guidelines were formulated and telemedicine was used, it really created a comfort of use of digital health for the patient as well as for the doctor, because fear for life, be in the same physical space, prevented us and actually promoted the use of distant and remote telemedicine, which is a great thing that happened. In fact, I would say one of the best things that happens in COVID is promotion of digital health. Having said that, telemedicine guidelines, the way they are, the TPG guidelines, what was formulated in March 2020, fall way short of what is your requirement, because it is very rudimentary. It says consent management. There is no clarity. Supposing I'm going to do a telephone consultation with you, how are you going to take my consent and how are you going to record it, right? So some of those things are not there. The drugs that you can prescribe, the clarity is not there. How long would you keep a record? It says that every consultation has to be recorded and kept. How long, in what format, how much storage is required? There is no clarity. So the people who practice it today also are practicing it in the way they understand it. Now, there was also, because whenever there is chaos and there is an opportunity, a lot of people come up with solutions. So you have a lot of people who came up with telemedicine solutions. There were a lot of applications. And many of them, we assessed many of them to create a telemedicine registry so that it could, people could know where to, it's like a one-stop shop for where you look for a telemedicine solution. We found many developers did not know anything about the guidelines. They don't know that there is a guidelines that they have to adhere to. They have to provide for identification of patients. They have to provide for identification doctor. They had no clue. Similarly, now when you practice in telemedicine, you could be sitting in any part of the country, any part of the world, and you would do a consultation, remote consultation. Whereas physically, if I have to consult in Kerala, I have to have Kerala Medical Council registration. When I move to Delhi, I have to have a Delhi Medical Council registration. When I move to Punjab, I have to have a Punjab Medical Council registration. Now, when you do telemedicine, I could do across without any registration. Right? So these kind of lack of clarity is there, and it is being it has a potential for misuse. Now, when you say that the patients will give consent, towards, we are moving in digital health towards a PHR, patient control documentation, who's going to educate the patient how to give consent, how to give right of access to a doctor? We don't know all that. So whereas for a crisis management, the TPG guidelines were excellent, came as a savior, it created a lot of opportunities for people, but we have to understand that we are, embarking on a journey of digital health. We're saying that we want to make NDHM a success. Telemedicine is the basic building block for digital health. Now, if I were to say that ASHA worker is the basic, the root or the basic worker in a brick and mortar healthcare work model, just next to PHC, and so is telemedicine. So if you want to have a robust digital health program in the country, telemedicine is the ground layer. We need to make sure that the first point of data collection has to be really robust, well adapted, and guidelines have to be crystal clear. So it is time to really look at these fine print and bring out the act. Similarly, and from there we move to the PDP and all of that stuff. Really, I think a lot more work has to be done, but it's a journey well begun, I would say.
Thanks so much.
Yeah.
Thank you. Thanks for those remarks, Dr. Nambiar. And I think similar themes that I spotted in your initial remarks as well, especially around data and privacy, and maybe we can come to a few of those and some of the more sort of fine print related issues in the next hour. I'll now invite Mr. Sridhar as well for his opening thoughts, particularly with your experience in building and scaling up UB Care, connecting with multiple points in this healthcare delivery chain. How have the laws helped? Where have they sort of not helped? And any other thoughts that you may have?
Thanks, Srini. And I think the opening remarks of Dr. Madan Gopal and Dr. Uma Nambiar summarizes it quite well. I will lay it out as a perspective of, as a healthcare company, as a startup, our journey and where we have been. So we started in 2017, to be very clear, on September 28th. So that was pre-pandemic. It was pre the telemedicine guideline time. Although telemedicine was very well accepted by the time frame, it was pre that. So I will talk about what happened to our journey before that and what happened to journey post that. In a way, capturing some of the things which already has echoed by Dr. Uma Nambiar and Dr. Madan Gopal. So we started with a journey of taking up follow-up care patients at home, largely post-acute, post-chronic, people with serious illnesses, where we felt once a person is discharged and sent back home, he's seriously missing the extension of a specialist care. That's where we said, why not we actually go to telehealth care, use telehealth care. Now, we looked at from that point of view and said that we'll extend specialist care to patients at home. And when the patient is being guided by the specialist as well as a doctor, we have a combination of virtual and physical, what we call a hybrid model, where we said that, okay, this is how the care is being delivered. So pre-pandemic, in fact, in 2019 to be exact, sometime, I don't remember the exact date, there was a guideline issued by the KMC, which kind of banned telemedicine. That was a big blow to what we were doing, in the sense that every doctor you go, they say that, oh, this is banned. I mean, you really can't do this. I mean, so we are saying, well, look, you're getting your patient outcomes. Patient outcomes are going to improve. Everything else is going to be fine. But of course, so what has happened pre-pandemic is the way people have interpreted, I mean, the guidelines, what is required for telemedicine at different states and different, was very, very difficult. Of course, the pandemic and the form that the guidelines have indeed come did help a lot in kind of this acceptance. And as this acceptance came about, it became much easier to actually say, okay, how the patient outcomes can be done. In fact, we have, as a UBCare, BIRAC encouraged us in terms of saying, how can you repurpose the COVID platform? How can you repurpose your platform for COVID? And we actually delivered COVID care to patients at home with great successes. Our platform was taken by St. John, who adopted it and provided telemedicine and COVID support to over 2,500 plus patients. So this kind of a support really enabled. So if you look at the pre-pandemic, there was certain regulations and it was like everybody interpreting its own set of laws and how to go about doing it. And post-pandemic, of course, it became easy. And the journey kind of embarked into a mechanism how to basically take care. Now, it's just not pandemic. It's just not a mechanism of what you call, like Dr. Umar pointed out, telemedicine is a basic element under which the entire digital healthcare is revolving around. But you can't just use it as a teleconsult. Just to stop at this point, I'll continue in this. If you look at a general clinical consult between a doctor and a patient walks to an OPD, the doctor actually does the consult, gives a prescription in a physical format, the records are put in some frames, maybe in some files, and the patient actually walks away with the prescription and buys the medication. The entire digitization is, you're just replacing this physical infrastructure by a virtual one. So in a way, the doctor is not changing, the patient is not changing, you're just bringing a new paradigm where you're just connecting them all together, right? Of course, you need other privacy, other policies and guidelines to actually conduct this matter in a way that it becomes efficient and the patient outcomes are indeed properly done. Now, so coming back, so when you actually look at, if you use telemedicine from that point of view, and you look at digital healthcare, it's not just teleconsult. Post the consult, what is happening to the patient? What are the different care flows? What are the care pathways? What are the different steps and guidelines? The feedback, what we call the closed loop feedback, has to be managed. This entire flow has to get covered into the process. What has happened at this juncture of time is we have set of guidelines for enabling this telemedicine. Of course, there are certain things which needs to be, but the practice has to go beyond this to enable the complete care. How is it being delivered to a patient at home and how the outcomes are indeed benefiting, so that entire community can work together toward the direction. So that the focus should be in the direction, and I believe it is evolving and it is in the right direction. And what we need to do is that, okay, step by step, we can actually put into those practices and enable that. So the focus should be not just the telemedicine, digitized healthcare. How does the patient outcomes are indeed getting improved has to be the basic theme under which one has to be focused on. And I believe we are in the right step. And of course, a lot of things yet to be done in the direction.
Thank you so much, Mr. Sridhar. And yeah, I think beyond telemedicine, all of the other tools and sort of building an ecosystem around where, like Dr. Nambiar said, I think a stepping stone could be telemedicine, which has given sort of like a shot in the arm to a lot of the digital health initiatives, but there's perhaps a lot more to dig into. And we'll hope to hear from you through the course of the session on some of the other aspects as well. But maybe if I could spend a little bit more time just on the telemedicine practice guidelines, perhaps if I could direct this to Dr. Nambiar, because I think you did mention that there's a lot still in the fine print itself, which can be enhanced or improved. Perhaps maybe if you could talk about some of the sort of risks that you see or envisage to patients and both to doctors relying on mobile health applications, given the current set of guidelines. Do they place too much of an onus on physicians and doctors to be calling the shots? And do they do enough to kind of apportion liability and ensure accountability of the tech platforms? Would love to hear from you on that.
So not just for telemedicine, but for the entire digital health platform, when we talk about, capturing electronic data and the entire breach of security, anything, where does the onus lie today? The responsibility lies with the doctor or the hospital to ensure that there is no breach of security and that, you know, all that, because there is no clarity. Now, as a hospital administrator, if I buy a software solution and there is a breach of a patient's data in that solution, the patient sues the hospital, right? And the patient, and also the concerned doctor who has captured the data. There is nothing mentioned about the technology partner, the software company. There is absolutely no guideline which says that so and so will be responsible, because that is where the government needs to step in. That's where the guidelines needs to come. Because today, even if I ask a software company that, okay, I'm going to audit the security features that you have put in, they are not open to audit. If I say that, okay, when my hospital is going to be audited for accreditation or anything, I'm going to ask them to audit your security systems or the data storage and all that, they will not subject themselves to audit. It's not part of the contract. So there is a big lack of understanding, and there is a fear, you know, for a hospital administrator or a doctor, because first of all, we don't understand anything about where this breach will happen, what is this data security, where will the data be stored. We have got zero clue about all that, right? So the knowledge is not there. And it is not really the domain of the medical fraternity to be looking at the storage of this data or the security of this data. It was different when you had a physical document and it was in the complex of the hospital. You stored that physical document in the complex of the hospital, and the hospital was responsible, therefore, for the physical security of that document. Today, that is not so. So I think this clarity needs to be there before the hospitals and the doctors feel confident that we will not be sued for something which we have no idea of and we have no understanding of, and we also do not have any reason to be responsible for that. We are the data capturing community. Our job is to capture the data accurately and to look at the analytics and to use that analytics for better patient care. But in between, storage of data, security of data should not be something that is held as a responsibility of the medical care provider. This is what I needed to say.
Sure, thanks, Dr. Nambiar. And yeah, I think you bring out the distinction as to just what all is the scope of work of a hospital versus a tech platform as well. How it's kind of different when it's a setting of this sort. And I'm wondering if I could ask Mr. Sridhar on from the other end, as a tech platform that is often looking to onboard doctors. Is there something more that can be done there? Perhaps some more training at the time of signing up so that doctors are also more comfortable and really understand how to handle data and how to kind of interact with the tech platform better.
Yeah, sure. I mean, it's possible. See, in any platform, I mean, because see, for time being, if you remove the digital telehealthcare and look at other platforms which normally are so tuned to use right now, like for example, mobile, like example, the personal computer itself, like many. If actually you should look at them as tools, right? So in any platform and any specific thing, there is a usability aspect. So what we let's say call the user interface, or what comes as from where you're actually able to use and how to basically go about. And there's a whole backend which is actually supporting this entire thing actually happening. I'll just deflect it for timing to finance transaction. Look at banking. All of us today are equally comfortable in using and doing online transactions. We have been sending money. I remember the days when I was young and we really have to put checks. I was in a hostel and my father has to literally send a check which has to be put into my account and then it'll go. It takes such a long time. Right now, all of us are adapted to it. Security, for example, there. Now, of course, like Dr. Nambiar mentioned, there will be audits. There are other things which you will need to do, which ensures that you're stamped with respect to that security. So the backend portion of the entire thing, which takes care of the EHR, the basic flow of how the care workflow should go about, and all those are residing, and that provides the interface. And the front-end interface should be a mechanism where it should make it as easy as possible. To an extent that, like we are communicating right now, why not? Technology should be as easy as possible that I'm communicating right now, and it should be feasible. However, because technology itself is an evolution, so today, for example, some forms have to be entered, some mechanisms have to be put in, some login accesses will be there. To that extent, training, onboarding, everything else can easily be doable. And our goal is to ensure that the front-end interface to the medical practitioners, the doctors, whoever, we will try to make it as simple as feasible. At the same time, ensuring that the captured data and whatever information is being captured by the practitioners is as per the norms and guidelines and put in secure mechanism and ensuring that security is there. I remember when we were actually demonstrating this to St. John Hospital. Now, in St. John Hospital, multiple doctors came with multiple queries. One specific query was with the psychiatry. Now, this department says that I don't even want my other doctors to see this specific data. Can you actually make the security, because it's now in this case of situation, it's more like patient-doctor thing. I really need it to be 100% secure. So now we have to come back with some sort of a mechanism. We still have not come with, we're not given up that solution, but we have to formulate some sort of a vault. Now the problem is, next question is, in the event that the doctor really lives St. John, now, how does this data become available to some other person who's going to take over, so that those practices have to be put in? So technically, from a technology point of all this is feasible. The question right now is that what is the framework? What is the element? What kind of secrecy and what kind of privacy you need to put on each of the data elements can be defined and has to be structured in a place. And to answer your question back, can a training be done? Of course, training can be done. Can the interfaces can be simplified? Of course, it can be simplified, and that's the evolution we're working. I hope that answers the question.
Yeah, no, that does help. That does help contextualize, and I think it could be a segue to for me to also ask Dr. Gopal. I think there are a couple of measures that both platforms and doctors could take, perhaps more training at the time of sort of onboarding, smoother interfaces, all of that. But I'm also wondering how far can the law go in setting out certain standards and in setting out sort of even enforcement mechanisms around some of these things. Is there a need to granularly sort of prescribe a lot of this in the law? Because I know there is a reason for why there is sort of principle-based regulation, which is warranted in certain themes and in certain areas. And that's the sort of sentiment with the telemedicine practice guidelines as well. There are these broad principles, and then there is the detail is left onto the doctor. So if I could call you in to just speak about how far do you think the law should go in this space?
I've given you the context under which these practice guidelines were made. At that time, when we were grappling with the issues of preparing to face the pandemic, who was having the time for making details? Second thing, it was meant for the follow-up patients who were treated by the specialist, as mentioned by Sridhar. It was meant for them. But the industry has taken it as an opportunity, and we have opened floodgates for lot of platforms have come up. If we are creating any platform in the government per se, if I want to make a software for a government thing, we are having STQC certification for that. Unless and until the QCI accredited STQC certification is got by that software, that is not allowed to enter into the NIC system. In the private sector also, that kind of regulation is there. The upfront, when we are taking some software, we can ask that whether it has been audited for the security or not. Now we are having a lot of agencies who are doing security audits. Everything regulation, you talk about law, you are a law student and you talk about law. Ravisha, somebody is there. Surely laughing, you talk about law. There are many laws in the country and many things are to be regulated. But who is having the regulatory capacity to regulate? That's the thing which we are grappling. We are having so many laws. Even for the digital also, you would be having some laws to regulate this, but we are not aware and we don't have the capacity also. We have to find out that as the things are evolving, now these problems are coming. Now there is a need for enforcing some regulation. But will it solve the problem? We have brought that Clinical Establishment Act for regulating the health institutions, and this is almost a decade now, and you have seen the state of affairs of regulation. We have to see that how we set standards so that people, they do self-regulation rather than bringing an act and regulating and danda market come. No, that is not going to work. We have to see that how we regulate ourselves. We have to set benchmarks. If the institutions are there, the association will be there. They say that he will follow these standards. If any vendor is not able to come to that standard, we are not going to buy that this. The standards are set. That is 3 rated, 4 rated, 3 star, 4 star, 5 star. That kind of starring has also come. There is a good system in the government public sector. That means the STQ, Standard Quality Assurance Certification, is there under QCI, Quality Council of India. Unless and until a software or a tool which is there to be used that meets the standard, it doesn't come. In that, you can always build into the security and the privacy aspect into that. That kind of standards we have to evolve. We have to see that what standards are there. Second thing, as has been rightly pointed out, that as things are evolving, we have left a lot of the things to the doctors. We don't know. We can't be prescriptive at that time. We have to see that the workforce, many of the doctors who were having the private clinics, the small clinic, they all closed down. It has given an opportunity to these people also to see that how they can contribute to the ailing patients and other people during this time. And many of the private players, they have found it as an opportunity. The rough estimate is around 55,000 crore industry has been opened. They have made you find a lot of platforms and everybody is working in silos. One of the challenges which we are having for any regulation is how to deal with these silos and the fragments which have evolved, which have come up. We have to see that how to address this issue. A lot of silos is there. If I wanted 24/7 this teleconsultation or telemedicine, whatever you name it is, and nevertheless it's the same thing, we don't have. The e-Sanjeevani, which platform is there, it works from 10 o'clock to 4 o'clock. That's the time. If somebody falls sick at 11 o'clock, I don't know. Specialist services are not there. If you talk about any other telemedicine guidelines, some other practice has also crept in. We have to see that as things are evolving, the professional body should come forward and say that these are the minimum things which are there. Then we can start thinking about coming up with a regulation or this act. Otherwise, till that time, if we bring in regulation, people will say that it is not good. Let the practitioner, let the people have feel how to use it, how they can regulate themselves, how they can set standards. The people who are providing quality standards, they will survive. And we are trying to see that how we create a network of this platform so that Uberization of this can happen. And across the country, as Umaji has rightly pointed out, that no registration area, only one medical register number would be sufficient to practice across the country. There are many issues there. Things are evolving. It's hardly 2 years old baby. Now you have to see that these are coming and now you see that how it evolves. We set standards instead of asking the government to regulate it. We start having our own standards. See that if the vendor is not meeting to the standard, we will not buy that things. That kind of things can at least force us into some regulation. Immediately bringing regulation is not a big deal. We can do it in 3 months. But enforcing that, where are the capacities, whether it will be a public good, whether it will do more good than harm, that kind of options we don't know. Things are evolving. I'll stop here.
No, fair enough. I think what you say is very pertinent, that there's need for sort of more bottom up approach rather than handing down very prescriptive one size fits all type, which will not account for a lot of the nuances here. I'm also wondering, I know when the guidelines had come out, there was some scope there to say that for telemedicine, there could be, specialized courses or a certification that is handed out, which might actually equip trainee doctors and doctors to understand this a lot better. Dr. Nambiar, I wonder if you had any thoughts there on whether this might be the right approach.
Yes,
And
actually,
also
there were courses conducted for doctors by the TSI, and DH India was also part of doing that. But that is only teaching them about the telemedicine practice guidelines and to tell them that it is now legal to practice and that this is what you need to be careful about. How do you make sure that you at least stick to certain basic norms that have been dictated, which is about identification and consent and prescription, what you can do, what you cannot do, and to ensure that the fear of telemedicine is, they are not afraid of practicing it, and they are comfortable with it. So that, yes, so doctors have been trained to that aspect. And as Mr. Sridhar was pointing out, when we also deploy HIS and AMR systems in the hospitals, the doctors are trained and they are given the training. But so, yes, but as we were just discussing, there has to be an evolutionary process in the basic telemedicine practice guidelines, which, it's all in the process. It's just that because of COVID, things have got delayed and it's taken 2 years, I'm sure. Otherwise, by now, there would have been far more work that could have been done. But I'm sure more consultation is happening and more consultative process will evolve. And, discussions like this, which will, tell us as to what the future what we have to do in future. Because the guidelines surely have to improve and we have to bring them to, actually be usable in the normal times and not during just COVID times.
Fair enough. Yeah. And I think maybe on the theme of data, because a lot of you mentioned sort of data as one of the data and security as one of the key concerns that emerge with the use of digital tools. Was hoping to get thoughts on just the upcoming data protection law. There is one sort of baseline set of principles that is set out there, and this idea of embedding privacy within the very design of a lot of the platforms that are emerging, making certain privacy conscious choices throughout the life cycle. And if I could ask Sridhar, if any thoughts on how much, again, the law could help here, what are the kind of initiatives or maybe even choices you've made when developing your product when it comes to data protection and data governance, allowing seamless flow of data while ensuring privacy?
Sure. So let me answer it from the perspective how we approached it. Then automatically that kind of will answer your question. So the way we looked at is the EHR has been there. We've been there for quite some time, not just because the guidelines have been there for quite some time. What we were embarking out to do was enabling specialist extension to patients at home for the follow-up care. So we were not really looking at reinventing the EHR, because the EHR has already been there. So why not we basically use an existing EHR, which has what you call HIPAA compliance, wherein there's a certain amount of security guidelines already as part of it. This is what we're talking about before the telemedicine guidelines has come in. Before that. So we wanted certain protection. We also designed a consent format and everything else from patient. And primarily because the patient, at that point of time, even this privacy, telemedicine guideline didn't come in about patient being the owner of the data. If you really look at it, every hospital retains it, every diagnostic center retains the patient data. However, the way we configured when we took the EHR, we identified the base level EHR. We said that, well, patient will have a login access, and using that, the patient data will be available to patient. And when an assigned doctor is assigned to the patient, he'll be able to see the patient data by virtue of the consent which already taken from the patient. That's how we basically configure it. And then we build on top of the rest of it as how the care workflows, how the specialist is able to extend his care is what we actually as a mechanism we built onto the platform. So we actually use an existing EHR under which we build the rest of it. And our choice of that EHR was based on there is a certain amount of undercode HIPAA guidelines, which actually adheres to, which is forming a protection. Now, to answer your question from technology point of view, very theoretical, any protection is feasible because we have actually high layers of security protection on different kind of data, non-medical, which is already available in other sectors, right? So the platform is okay, with a level of whatever protection we want to decide and we want to basically put forward, whether it is by guidelines, whether it's by rules, or whether we as a company we wanted to ensure that the patient data is protected, it can easily be implemented. And that's what each and every, I'm sure, practitioner in telehealth is actually doing at this point of time. I don't know whether it answers your question. What you're looking at is that what should be the guidelines? Well, what should be the guidelines is a kind of definition which is coming in at this point of time. And primarily with the aim of saying that the patient, if I'm my end user as a patient, I've actually not here right now, I'm talking about 10 years back or 5 years back. I go to a diagnosis center. The diagnosis center gives me a hard copy and then retains some part of it. I go to a hospital like Manipal retains its patient. It gives me an ID. I go to some other hospital like HCG or Columbia Asia, they will have their own ID. Every time I go to different hospitals, I actually put my ID. I really don't have the collection of all the data with myself. What the digital health is permitting today is enabling me to have that. Now the question right now is from a practice point of view, we can actually put in saying that this should be governed by this kind of a privacy, this kind of protection. It is easily doable and it's easily implementable.
Yeah,
I don't know whether that answers the question. If that is,
yeah. No, that helps, and I think what you said earlier about sort of just access controls and managing access as to who views it beyond just security, but also privacy. Some of those choices help. And so we advise a lot of sort of both B2C and B2B platforms around data generally and health in particular as well. And I was just wondering if I could quickly bring in Shambhavi from my team, maybe just to talk about some of the commercial learnings and commercial aspects of what, maybe just to contextualize the conversation here. That would be great, Shambhavi.
And
Sure.
I'm just going to interject, Srinidhi, we have got some great questions as well. So maybe once Shambhavi is done, there are a couple of questions that I think I'd like to pose to all the speakers today, which are more about building the ideal kind of regulatory network. So maybe once Shambhavi is done, I can maybe address some of these questions that Jerry and a few others have posed. Over to you,
Sure.
Shambhavi.
Yeah, sure. No, thanks for bringing me in, Srinidhi. A couple of clients that we've advised have pointed to how you can have, say, a master data account. Let's say I'm the head of the family. I have 4 family members using my mobile phone to get mental health support or even telehealth support. How do I protect their patient rights? How do I ensure their healthcare data is not corrupted? And we've seen some interesting use of dashboards and in-app communication tools. So things like hanging notifications, things like dashboards where you can granularly kind of choose what you want to share with whom and under what circumstance. Some cases we've even seen people use OTPs. So let's say my daughter wants to use the app independently of me at some point. I can't access her data without her keying in the OTP that comes to her phone number. So there are different ways in which you can communicate with your patients and people using your app, that you are privacy compliant, that you are implementing privacy by design, that you aren't collecting data en masse just for the sake of collection, and that there is a reason for every data point being collected. There are ways that you can do it within the user interface, which is something I think Sridhar sir also sort of spoke to in the beginning. And this, it's just interesting to see how these are evolving as industry practice in the absence of any requirement from the law to do so. And it's just been a fascinating exercise, especially with the TPG coming in, especially with digital health tools coming in and really changing the way you can do home monitoring and remote monitoring of patients. But I will stop here so that maybe Dr. Priya can look at questions.
Can I just make a comment on privacy?
Sure.
So this is about I always feel that we cannot just copy the privacy laws that are enacted in the West. We have to do our own laws. And simply because if you look at some of our hospitals, when the patients come, there is a whole village, which comes with them, and the patient is exposed in public, and they're showing they're talking in front of them and all of that stuff. When we talk of telemedicine, I mean, on the one end, you have solutions like what Shambhavi was just mentioning, and you have families in Bangalore, Delhi, Bombay, which actually understand this context. You have in villages telemedicine being done where there is a kiosk operator, and the entire village actually comes there, ki doctor sahab se baat karao, and then doctor sahab se baat karao, so then this whole thing, whether it is women with a vaginal discharge or a lump in the breast, or there is or there is a mental illness, it's all being discussed in public. Okay, everybody knows. So we need to make sure that we Indianize what our privacy laws are. For us, privacy about some of these things is not a big deal.
Maybe Dr. Priya, if you could take up a couple of the audience questions till
Sure. Actually, one question that is posed by Jerry Bloom, and this is, I think, across perhaps both Mr. Sridhar as well as Dr. Gopal can address this. I mean, his question is, what are the implications for the development of some of these regulations for poorer patients who really can't afford to pay for doctors' care? So what are the implications of
Sorry, I
regulatory
got
reform?
disconnected, but I think you understood. You got what I was saying.
We did.
Yeah, thank you.
I'm just actually posing a broader audience question to across the panelists. And one of them that's just come up is from Jerry. And he basically asked, what are the implications of the development of some of these newer regulations for poorer patients who can't really afford to pay doctors for care? So can telemedicine and digital health in a broader sense support greater equity? Or is it mainly a service for the better off? So perhaps we could kind of, move around the panel to see how you would like to feel this. So why don't we start with Dr. Sridhar and then Dr. Gopal and Dr. Nambiar.
Anyway, I'm not Dr. Sridhar, so you can just address me as Sridhar.
Yeah.
So actually, this is a very good question. And both founders in UBCare, we strongly feel about that. So that's why we started with follow-up care. Now, if you look at it, how many patients are lost to the hospital post-discharge, like cancer, stroke, or any of the neurological diseases coming from these sectors of what you call Tier 2 or Tier 3 or even villages? You can see Bangalore, a host of these people come from eastern part of India, northeast or the eastern part of India coming to Bangalore. And a lot of these people actually sell their properties and everything else and come here. A lot of times money is over, they go back. Now, half of the problem is only solved. The problem is not that they really are not able to. They're lost in the follow-up care. Telemedicine, telehealth care makes this very much feasible. Obviously, there's a cost associated. It's not because technology is possible, but there's a cost associated. Whenever there's a cost associated, we assume that somewhere the money is going to come in. Now, for example, either it's the government or through the CSR funding or some mechanism. But the fact of the matter is that the moment the follow-up care is being delivered at the patient's home, the cost automatically reduces. One, there's no travel. Two, they don't really have to spend in a city, which is not their own city, where they have to spend a lot of money, not to mention other clinical aspects, other costs. So the cost is automatically reduced. The question right now is that with respect to whatever is being done with respect to follow-up care, or when we're doing digitization of care, it can really reduce the total cost of the care, overall cost of the care. Well, as a mechanism, because there is people involved, somebody has to be paid in making the care happen. So some amount of this financing and other aspects can come through other sources and other funding mechanisms, but definitely the cost of care does reduce.
Dr. Nambiar, would you like to kind of take a shot at this question?
Sure, because I firmly believe that telemedicine is surely not only, it brings about equity in healthcare, but also improves access. And a lot like what Sridhar said, that also reduces the cost. I mean, just to give you an example, that it's not only just a follow-up, it's also for first consult. When patients are from the Tier 2, Tier 3 towns are scouting for specialties and hospitals in a Tier 1 town, they have a much better opportunity now to explore digitally, to get their appointments, to get their, investigations reviewed, and they're, not to have to repeatedly investigate themselves. Because I've seen how if somebody from, Bihar came to Delhi, he would have a stock of investigations, and when they come to Delhi, either they are not being, they will be asked to repeat those tests. They'll say, "Ji, hame pata nahi," things like that, and they'll be asked to repeat CT scans, going from one place to the other, either because the films have been spoiled or the storage is not all right. But today you don't have to do multiples of investigations. So your investigation cost before you reach the actual specialty where you need to be treated is reduced tremendously. And you need to then travel only if required, because you don't have to, for every small thing, come to Delhi. You can get treated in, the local hospitals. So that way you will find that you will introduce more efficiency in the entire system of care, and of course reduce the cost as well as, make it more equitable. And of course, I always feel that it will also bring about more transparency and ethics, because while what you are doing and it's in the digital format, more doctors have access to it, more people have access to it, and more reviewers are there is going to be more transparency and, reduction of cost, and not having to repeat multiple investigations will bring about a lot of transparency and eventually increase the trust quotient, which is so much depleting now between the patient and the doctor. So, I mean, that's my belief in this.
Thanks. And Srinidhi, actually, there's one more question. I just thought that.
Priya, let me answer this.
Yeah, sure. Sure. Actually,
Okay.
and I have another question
No,
for
no,
you,
regarding this,
Dr. Gopal, as well. Yeah,
Because
please go ahead.
regarding the regulatory thing, if the question was, if the regulations come, whether it will affect the cost to the poor or not.
Yes.
We should understand the landscape of the healthcare system in the country, where each and every person, including me and you can walk into any of the government institutions. If you are a person belonging to a poorer section, all the cost is free of cost to you. The government will bear the expenses for that, including the high-end investigations. For me and for others, it would have to be a nominal cost, which is far less than the private sector. When these telemedicine guidelines are there, which are already in operation, if you look at the structure, we are having around 150,000 sub-health center, which would be upgraded a health and wellness center. This will be the first contact of the person, rural person, for accessing this medicines and the care. This health and wellness centers are enabled through a telemedicine hub or the telemedicine network. Currently, the primary health centers they are connected with the eSanjeevani platform, which is a government owned, and daily you would be wondering that what kind of hits this eSanjeevani network is happening. Though it operates from 10 o'clock to 4 o'clock, but the way it's more than 500 million calls have been made till now. So these are all free of cost to the persons who are utilizing it. That means even if regulations happen, the cost for the poor or the deprived section is not going to be there. It will be free of cost to these people. I will stop here for this question.
Thanks, Dr. Gopal. There are one or two other questions that will probably be directed to you and the others. Srinidhi, would you like to go ahead with those?
Sure. I think there was one question on, is there any recommendation or law to in India for AI filter clinics, like a general practice service which could automate?
I have already answered that thing in the question answer section.
Oh.
Currently, there are no recommendations.
Right. And I think another question on integration as well. You've taken.
I have already answered that thing, and it's visible to them.
Sure. I think another question that would love to hear everyone's perspective on was just how could maybe regulators help infuse trust in digital health tools, be it apps or software or wearables or other such platforms. Will a thorough vetting process for apps or digital platforms used in healthcare help? Should they be regulated as medical devices? Is there a need to tweak the current law? Any thoughts on that? Question to all panelists here. Maybe if we could start with Mr. Sridhar and then.
Sure. See, actually, it's an interesting question. See, anytime anything new happens, you actually look at the whole gamut of all the areas, and there could be the trust element becomes a problem, essentially. You don't ask such a question. We talked about it, the virtual infrastructure versus physical infrastructure. But you don't ask such a question in physical infrastructure, primarily because the doctor's certification is there. There is a medical council which is actually certifying the doctor do thing. The drugs which the person is actually buying is also certified. There's a mechanism there, right? Which is all there. Now, the basic thing is that underlying the communication which is happening between doctor and the patient, which is a digital healthcare platform which you're putting in. What are the kind of things which needs to be put into practice so that a trust comes in is the mechanism which needs to get in, right? Now, like Dr. Uma Nambiar talked about it upfront, that just by sheerly putting in a list of people in the into a list will not be probably good enough. The question right now is that there is a data protection, something which is required. So maybe some sort of a certification or some sort of a mechanism of, let's say, like what you have for ISO standard or something. When somebody takes it, automatically there will be some mechanism with that. So that kind of could be an act. So likewise, you can have some guidelines to do that. But if it cannot be something which actually puts too much emphasis on, let's say, like you have to pass some sort of you have to get some sort of a regulation to actually go and get a signature to do it. That way speaking, then all the innovation, everything else will get curtailed. I mean, it cannot be some sort of you need to apply for something and then get in return. So it could be there could be a certain thing like ISO standards or something which we can put in, and then definitely a list of all this approved software vendors over there. If thing will be there, will definitely help, I believe. It's a question of enabling a trust in the system, and some mechanism of when the trust comes in, everything will automatically work towards making the right things, is what I believe.
Dr. Nambiar, would you like to come in as well on this?
Yeah. So one is, we have to understand that when we say use of digital technology, it is not going to be like, we should not be doing a copy paste of what we do in the paper world. Okay, we must use the digital technology for its ability to improve the efficiencies of the system. That is very important, and that is what we all have to in the healthcare system also understand. Like as a doctor, I shouldn't say this is how I do it now. So ask the EMR vendor, you create the screens like this and do this process. So that's important. The other thing is that yes, regulators, what has to happen is, yes, there has to be a hand-holding, there has to be guidelines, but it cannot be dictatorial, it cannot be restrictive, it can be enhancing. And we should refrain from pasting, copying whatever the Western world has done, because there are innumerable problems in the digitized world which they use in the healthcare sector. We need to make sure that we use our capability. I mean, Indians have the best capability in terms of creating the IT solutions, and we should create our own systems which get followed by the world and not the other way around. And I think, our NDHM, the entire movement is something that the whole world is watching. So how to make it more robust? It is not through restrictive acts, but through enhancing guidelines, and to see how we can improve the collaboration between the tech world and the healthcare world. Because at this moment, what we find is that the healthcare worker has to listen to what the technology developer says, that this is like, it's like, so the healthcare has to work for the tech that has been developed. It should be the other way around. Tech has to develop for healthcare rather than health to practice as tech.
Fair enough, yeah. And Dr. Gopal as well, if you'd like to also come in on this. And I did see there were a couple of other questions also which you responded to. One being just this question of capacity, even if we were to have a vetting process, and I'm hearing from both Mr. Sridhar and Dr. Nambiar that might not be the way to go, very prescriptive, but would love to hear your thoughts, especially from the perspective of capacity building as well.
I will just pick up from where the Umaji has left. That is, the practice needs to be built into technology, not the vice versa. The main thing is that the technology tries to push the practice. As a result, the conflict arises. We do have the health technology assessment, which is still evolving under Department of Health, Department of Health Research, under Ministry of Health. So that thing is evolving, and if you look at the staffing pattern there, so a lot needs to be done there. Right now, they are just doing the costing of packages and the thing. It was designed to be like the things which we have witnessed in Thailand and South Korea. Now it is moving in that direction. When whatever things are coming, I want a health technology solution to be included into PMJ. Right now, their focus is on bringing in the packages into the PMJ program. So they are just focusing on that, but slowly and slowly this would be added. During the COVID time, you see that how the Department of Health Research, they have evaluated your diagnostic kits, and as a result, you have seen a lot of change in the way which the treatment and in which the prices of the diagnostic kits, they have come down, because the evaluation, the other things, it has evolved. But still, for having a technology-based solution for evolving this kind of thing, though we have an Atal Innovation Mission at our base, which nurtures the startups and other things, but for evaluating the health technology per se, that capacities, we have to see that how we build that capacity. A lot of work is to be done on that.
Thanks, Dr. Gopal. And I think a quick follow-up question there perhaps could be within the current Drugs and Cosmetics Act framework. Also, there is a committee that is, I believe, looking at sort of revamping it, addressing, examining what more needs to be done. So I was wondering if the panel also had thoughts on what could be the priority areas for the committee to look at when we're thinking of drugs and cosmetics as an umbrella framework for also devices and products. And just on capacities of the existing drug controlling authorities?
It's a very difficult question to answer because a lot of things which are discussed can't be shared here. So I can't be sharing that thing because what has transpired regarding the Medical Devices Act and other things, it's very difficult for me to answer this question. I'm sorry for that.
No, I completely appreciate that. I think I was also trying my luck there with that question, but would love to hear from Dr. Nambiar and Mr. Sridhar as well, perhaps on what their expectations would be from this redesign.
So let me talk to you about the medical devices. I mean, just like how in the last 2 years, we've seen a plethora of telemedicine solutions, we've also seen innumerable apps and the IoTs that are just mushrooming. And it's like, every app you upload one and you install one and uninstall 4 every day, right? It's almost that kind of, scenario now. You have so many available. And there are no standards, which, many of them are there too. Some of them, not because they don't want to, but because they do not know where to go look for and what are the standards. And it is nobody's fault that we don't have those standards in place as yet, because these are all things in evolution. So what will happen is over the next 3-4 years, I think the ones that are not adhering to certain guidelines or are not keeping themselves ready to adapt to the evolving guidelines, they're going to, go out of the system. But the next 3-4 years, we will have to live with a lot of breaches. Okay. We will have to live with chaos. We might have to live with solutions that we have bought and we'll have to discard. So we will have to pay a price. A lot of us will have to pay some price. Hopefully it may not be too serious, because it's in that over the next 3-4 years, I think a lot of things will fall in place, because the work is happening in that line. I'm sure Dr. Gopal is so much aware. He's not telling us, but of course it's all happening, and it will all be in place. These standards will be in place. What everybody has to see is, the developers, the technology developers, as well as users like us, we have to understand that we might be using something which is going to be short-lived. And there will, of course, be a lot of, big players that will come in, and, all that will happen. But yes, we have to be ready for this living out this chaotic period.
Yeah, I definitely agree with that. And only thing which I can put in forward is that definitely we don't want to have medical devices covered under Drugs and Pharmaceutical Acts, because they are two different things. So how exactly this is going to come about and which way it is come about is something we'll wait and watch, like what Dr. Gopal has mentioned. Thing is, however, innovation is curtailed with more and more regulations. The more regulations you put in, the innovations will get curtailed. Today, for example, going to the whatever circumstances we are today, the world where it is, there's a lot of opportunities in actually coming about and getting a lot of these things in digital healthcare. What has happened in other areas in IT and other worlds can really touch the healthcare space, and how we can actually nurture and capture that is something the rules and regulations will actually guide. So definitely one can look at it. I'm sure, it's just, it's not rocket science, and that's what probably is happening, and it is going to evolve. And I'm sure that we will have spaces of saying that, okay, there's wearables which are not actually doing much. But on the other end of it, there are things which are actually touching the body and doing something directly to the patient. So there could be different guidelines which can emerge there, and I'm sure that must have been taken in. So if it can be put into right shape, innovations will really come about and change the whole paradigm of the way we know about and the way patient and doctors are practicing medical health.
Yeah, I have to say that what you're saying, Sridhar, about this innovation thing, because we've seen in the last 2 years, the amount of innovation that has happened in digital technology or digital health. We've never seen it before. We have.
Yeah, I think
Great.
there's a bit of a lag. I think we may have lost Dr. Nambiar there. And while she rejoins, maybe I'm also mindful of the time. I think we're close to the end. So I'd really like for everyone to, I guess, weigh in on, given the scale, I think given the scale that Dr. Nambiar was also alluding to, what might be your wish list, say, for the laws and policies? Maybe 3 top points that that you could share with us on what you'd like to see in the law and policy framework for an enabling regime. If maybe again I could ask Mr. Sridhar to weigh in first, and then Dr. Nambiar, and then I'll go to Dr. Gopal.
So basically, the key thing here is that enabling the trust in this area would be primarily, I'm sure that's what the government is addressing also, is the personal data protection, what are things which needs to get take care if that can actually come by fast enough, where with a single legislation which can deal with the personal data will definitely be of help to us. Okay. The second would be like the question right now is that what is the scope? I mean, Dr. Nambiar alluded to that. Today, for example, how does what is the difference between one state practicing in another state, and what are the limits about that? How are the practitioners going to practice across different state boundaries? What is the clarity? If that something can come about there, that will help. And of course, because this is again bringing trust into the element, what kind of a certification process for having the digital healthcare service providers as a repository? What kind of guidelines can work in that, so that people, I mean, you can actually build on top of that, is what I believe immediately would be of focus to companies like us.
So, I feel that, a few things. One is that the entire culture of innovation that has seen, a real increase in the last 2 years. I think our country needs to make sure that we encourage innovation and we encourage financial support for young innovators, and also the domain specific knowledge experts and platforms which should be there, because many of them are working in isolation. And I think that the culture of innovation has to be encouraged, and there has to be that is something that the government should look at. Second thing I feel is that in our education, in the medical, nursing, and health technical education, there is really no emphasis on digital health related education, and it has to be done on an urgent basis. If supposing somebody has to introduce it as a subject in the final year, or in the nursing informatics or medical informatics, it has to be as an undergraduate subject, so that when the students pass out, they know it becomes normal practice. It's not something which is coming, which they have to learn again. And so that's something which I feel is mandatory. And the third thing is that there has to be an environment where the technical partners and the healthcare domain partners have a larger platform to interact, to really understand. I'm a technical developer. When today they want to start developing a solution or a device, they go because they have a story in their own family. It's not because it is the need as felt by a doctor or a nurse, but if they have an interactive session, if they have ways where they can go to the hospitals, they can understand from a nurse how her life could be made easier, they would do it better, rather than saying, I went to the hospital to show my child, I saw a nurse was doing like this, and I developed a solution. It could be better if there is much, and surely the healthcare people also, they become more open-minded about discussing with the technology partners. So I think even at college levels, we need to have these kind of interactions, so that is important in my view.
Thanks, Sridhar and Dr. Nambiar. And
Dr. Gopal has just messaged that he's has to leave for another session, so maybe we'll just get the closing remarks from him, so he can kind of move on to his next session.
Okay, thank you, Priya. And after listening to that, let the things evolve rather than regulating it. Because the moment you start regulating the innovations and the other things which can come in, they will be just, you'll be killing the innovations. You will be killing that innovations. In 2 years, you have seen a lot of innovations. People have come with new ideas, how to reach it. We are having a lot of proposals every day. How to use the telemedicine network in the health and wellness centers. they are coming with a different solution. We don't know which kind of solution which would, for which part of the geography would fit, which part of the other aspects would be useful for the different set of patients. We don't know. Let the things evolve. Till the time, I think we should not be talking about regulation. Too early to talk about regulation, because nothing wrong has happened till now. We have left it to evolve, and when the things are evolving, you see a lot of innovations coming in, and then the best practices can be adopted elsewhere as well. I will stop here only. That's my only thing. Okay, thank you. I have to attend an Empowered Group meeting, so I have to leave it. Thank you very much. Okay, thanks.
Thank you. Thank you so much, Dr. Gopal.
Thank you, Dr. Gopal. We hope
Thanks.
to stay connected. Yeah.
Great. I think we're also close to the end of time. Thank you. Thank you so much, Mr. Sridhar, Dr. Nambiar, for your time. Really enjoyed this conversation. I think a couple of sort of quick thoughts, just summarizing everything that we've discussed. And I'll just probably start with what Dr. Gopal said. I guess adding more laws might not be the solution every time. And that's a very comforting thought, honestly. I mean, even as a lawyer, I'm happy to say that. I mean, would look towards more enforcement, perhaps, of existing laws, look for more bottom-up industry standards as the way to go forward. I think Dr. Nambiar made a couple of interesting remarks on tech should develop for healthcare, not the other way around. Encouraging any regulation should encourage innovation, financial support for innovators, and this theme of law or guidelines should not be overly prescriptive, but rather enabling, and the need to have more digital literacy and also literacy curriculum within colleges, schools, starting from the ground up. Mr. Sridhar made a lot of interesting remarks, I think, on infusing trust to see how the personal data protection framework could help move this conversation forward, some type of certification process perhaps for service providers and vendors to help build trust. In an ideal world, medical devices should not be regulated in the same way as drugs, because completely different regimes. And again, this overarching underlying theme of enabling regulation, which while ensures sort of patient outcomes, but it's also permitting innovation to arise. And with that, I think I'll conclude, and thanks so much for your time, everyone, and probably hand over now to Professor Jerry Bloom for his closing remarks.
Well, okay. I mean, I guess I've had the privilege of joining this meeting from the UK, and I have to say, I found the discussion very inspiring and very encouraging, really. It's clear there are major opportunities for digital health, but I guess you've all said there are potential problems. And the story I heard is over a number of years, a gradual buildup of digital infrastructure. With the COVID emergency, a game changer, and almost explosive accelerated change, very rapid development of a highly fragmented ecosystem. And then from everyone saying there's a need for rules, need to clarify roles and responsibility, need to build trust, really need for some governance arrangements. But then there is a tension. On the one hand, the need to leave room for a lot of innovation, but the need to get more rules and more clarity on who is responsible for what. So a very challenging situation. And also from particularly Dr. Gopal talked about the highly innovative roles, high innovation that's happened, but the limited enforcement capacity. And he also emphasized, again, you know, in a situation of rapid change, rules and regulations can have good impact, but they may have unintended bad impact. And so one has to be cautious about rules, thinking they're the key solution. And in the end, the need for an evolutionary approach, and Dr. Nambiar is saying there are no blueprints. There's no perfect model to be imported. And India, with its very innovative tech sector and innovative medical sector, may be able to take a lead in thinking through the new approaches. But that brings big challenges. And I guess I just want to make a couple comments. I work on health systems, as does Priya. And for us, it's really excellent to be able to hear the voices of lawyers, of government officials, of managers of large facilities, of tech entrepreneurs, voices not usually heard in the health systems world. But then and we heard the complexity of the different points of view and how they can find a way of working together to build this governance arrangement, this trust, while change is so rapid. Of course, there were people who weren't here. And I guess I have to mention that patients weren't in this discussion. And clearly their view, if we're talking about privacy, we're talking about equity of access, we're talking about quality of services, are important. And only certain providers are here. As Dr. Gopal said in the end, yes, there's the government primary healthcare facilities are key providers. Their voices haven't been here. But in a discussion about the new governance arrangements, somehow all those voices will have to be there. And then I was very pleased to see a comment in the chat. Well, I'll read what it says. We need to develop forums at a global level where practitioners, innovators, business professionals, regulators, and researchers work on a single platform and inform policy. And I think from what Dr. Gopal said, on the one hand, people want regulations. On the other hand, some regulations may have negative impacts, and the rapid change is so quick we can't predict. And I think that comes to people like Priya and ourselves, and why we have established a platform for research and mutual learning on management of mixed health systems. Because in this kind of process of rapid evolutionary change, there's a need for systematic assessment of what works badly, what works well, and how to move forward. And I guess I would end this by saying there's a real agenda here for getting some systematic learning, particularly in a period of rapid change. And I think there's a responsibility now for the research community to contribute to the work, the really excellent work you're doing. And I think I'll leave it there, but pointing out that Priya is probably a key contact for this forum, and she may want to say something about how people can get in touch. So thank you very much for an excellent, excellent discussion.
Thank you, Jerry. Thank you so much. And yes, please do join us to be part of the mutual learning platform. I've left the webpage URL on the chat, and I will leave my I'll ensure that my email details are reached out to all of you all have registered as well. This has essentially become a movement for mixed health systems, and we are delighted to have these kind of dialogues where diverse stakeholders from across the health systems make valid points about the future of health and how we can write our own futures when it comes to healthcare from the Global South. So stay tuned for our next dialogue, where we'll talk a little bit more about scale integration. And here we will bring the most crucial aspects of healthcare, the patient voices, to kind of bring forth their views on what it means to navigate digital health in the future. What does it mean as a patient, and what does it mean as vulnerable populations? So thank you so much for your time. And once again, I'd like to thank all the speakers of today's session for a fantastic debate and their valuable time. Thank you again, Dr. Nambiar, Mr. Sridhar, and Mr. Gopal. Thank you so much.
Thank you. Thank you. Thank you. Bye-bye.